Bismillah ar-Rahman ar-Rahim. I hope everyone is doing fine. Today is going to be our one of the free sessions, in which we will be covering one of the important communication cases and one of the important consultation cases. So before starting, I would just like to know: is my voice clear to everyone? Am I audible?
Yes, clear,
Yes.
doctor.
Okay, thank you. So we will be starting with a communication case. So those who are beginners, just to tell them that in PACES exam, there are two communication cases, and you are given 5 minutes outside the station to read the case to prepare your case, and inside you are given 10 minutes in which you are judged on four different skills in both of the communication cases, and you are given 10 minutes in total, and when 2 minutes are remaining, like at 8 minutes, examiner gives you a prompt that you've got 2 more minutes with your patient. So we will be starting with a communication case, and after that we will be doing a consultation case. So Dr. Maria, I think you asked for the communication case. If you are here, let me know.
Yeah, I'm
Okay.
here.
Okay, so I will be showing you a case on the screen, and then we'll be starting in 3 minutes. You will be given 3 to 4 minutes to prepare, and then we will start.
Sure.
So can you see the screen?
No, now it's sharing.
Okay. So Dr. Maria, if you are ready, let me know. We can start.
Yeah, sure, we can start.
Okay, so your time starts now.
Okay. Hello, good morning.
Good morning, doctor.
I'm Dr. Maria, one of the doctor here in the hospital. Are you Miss Sarah?
Yes, I am.
Okay, and I came to know that you are Miss Julia's daughter. Am I right?
Yes, she's my mom.
Okay. Sarah, nice to meet you. How are you?
I'm fine, doctor.
Oh, that's glad to know. As you know that your mom is here for 3 days, so we just arranged this meeting to discuss few things about her. I mean, her current health and next plan of actions. Are you okay with that? If we have a discussions regarding that?
Yes, sure, doctor. Sure, I'm here to
Oh,
discuss about my mom's health.
okay, that's really good. I will try my best to address your all concerns. Before proceeding, I would like to know about like how what do you know about her health generally?
Yes, doctor. Actually, my mother, she's an old age lady, and she's living in a nursing home for her care, and
Hmm.
she had multiple health issues in the past in the form of, advanced Parkinson disease. Her heart is
Hmm.
pretty weak, and along with that, she has some, issues with her lungs. She had a lung cancer as well. And she
Mm.
was admitted, 2 months back. She was admitted in the hospital with an episode of aspiration pneumonia. And and she was treated pretty well with the antibiotics, and she improved with the antibiotics, and she was
Hmm.
discharged back home. So now she is admitted again in the hospital with another attack of aspiration pneumonia. So the doctors have called me to discuss her health. I have not
Mm.
met her so far, but this is what I
Hmm.
have been told so far, that this is another attack of aspiration pneumonia. So they wanted to talk and have a chat about her health.
Yeah, you're absolutely right. And Sarah, you mentioned that she has lung cancer. Is am I right?
Yes.
Okay, so how that was being managed, either surgical or she had any chemo radiotherapy?
I don't know, doctor. She lives in the nursing home. I don't
Okay,
have much of a frequent contact with her.
okay. And I would like to know, like Miss Julia ever gave any like last power of attorney or who is the next of kin?
I am the next of kin, yes.
And you are also the last power of attorney?
No.
Okay, that's fine. Is there anyone else from your family?
No,
Okay, that's fine. Miss Sarah, actually, we arranged this meeting, as you mentioned already. She's like old, frail lady. She's been nursing home, and she has multiple health issues already. And she has multiple back and through hospital admissions because of aspiration pneumonia. Have you ever thought of like management plans? Either should like, do
no.
you think she's a good for any intensive treatment options
I don't
or
know, doctor. I'm here to know the update. I want to know from your side what you people are thinking and what you people are going to do with her. I told you about the previous things when she was admitted 2 months
Mhm.
back, and she was treated very appropriately with the antibiotics, and she showed a marked improvement with the antibiotics.
Yeah, I can see, I appreciate your concern, Sarah. Actually, by considering like her current status, her and I one thing I just came to know that she also signed for the DNA CPR. Are you aware of that?
No.
Okay. Actually, I came through the notes that she has signed DNA CPR with her last visit to the GP. It means that if anything unhappened, I mean, if
Mm-hmm.
anything happened uneventful, she will not be
Mm-hmm.
resuscitated. This was decided by her GP. She was agreed with
Mm-hmm.
that, and she has signed that form already.
But doctor,
Are you
that's
aware
not
of
my
that?
point. That's not my point right now. My point is
Yeah.
about the current status. How is she doing right now? What you
Yes.
people have done so far, and what is she
Um,
doing right
yeah,
now, doctor?
I'm coming on. Yeah, I'm coming on that point. Now, actually, she has again aspiration pneumonia, and she's
Mm-hmm.
being treated for the antibiotics for last 72 hours.
Mm-hmm.
But like being doctors, we think that by considering her current status, multiple to and fro admissions, we are thinking supportive treatment options would be better for her instead of giving different intensive treatment options. What do you think about that?
What do you mean by supportive treatment, doctor? I don't
Uh,
understand supportive treatment.
Yeah, Sarah, I can explain that for you. Actually, we call it as a end of life care pathway. In that, we try our best to keep
Mm-hmm.
patients comfortable as much as possible to make their last moment of life pain free. In that,
Do
we
you
will
mean,
give
doctor, you mean to say my mother is dying? You said end of life. Is she going to die? I
uh,
told you so many times very clearly that she was admitted 2 months back with with same problem. She was treated with antibiotics. She improved quite dramatically.
Yeah, I can understand your situation completely. But Sarah, thing is that she's having a to and fro admissions because of the same reason. By
Mm-hmm.
considering her multiple comorbids like lung cancer, Parkinson's, being a Parkinson's patient, she will be on risk for the aspiration pneumonia. And we think again and again treating her with the antibiotics will not benefit her for the long term.
So,
Are
doctor,
you
why are you giving up so quickly on my mom? Why are you giving up on her?
Um, Miss Sarah, I'm really sorry that if I gave you that if I give you that intention that we are giving up, we are not giving up. We will treat her, but I'm saying that we will manage her symptomatically. In that, we will treat the patients with the IV fluids, IV painkiller medications, or subcut more for morphine. That's a painkiller
Mm-hmm.
or control the secretions. But in that
Mm-hmm.
situation, we just avoid to treat the patients intensively, while like the broad spectrum antibiotic she's on.
Mm-hmm. Mm-hmm.
Are you
So,
getting my point?
are you going to stop these antibiotics?
Like yes, because end of life care pathway includes only asymptomatic treatment options. I'm really sorry for that, but end of life care only includes a symptomatic treatment, which will covers fluids, painkiller medications to control her secretions and keep her pain free.
Mm-hmm. 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 So, how long do you think she can survive like this, doctor? Like, what are we looking at here?
Um, Sarah, at the moment, like we can't say like for how long she's going to make it. But
Mm-hmm.
thing is that she might recover as he was being treated with antibiotics already for 3 days. But thing is that again and again treating with the antibiotics, she will be always on the risk for the aspiration pneumonia.
Mm-hmm. So what do you think? What could be the possible life expectancy here with my mom?
Um, it's really very hard to say that in the days or the weeks, but we can say that it will be
Mm-hmm.
weeks. But
Mm-hmm.
I'm not in that position to give you exact time period for her, like how long
Mm-hmm.
she's going to make it. It depends how
And
she's responding. Yes.
and what do you think, doctor? Like, what do you think? Can I take him back to the nursing home because there she had a lot of friends and she was quite living happily there. So what do you
Yeah.
think? Can I take her back to the nursing home?
Yeah, end of life care. I mean, these things, whatever end of life care patients can be managed is the nursing home because they have their, they can, these can managements can be possible at nursing home as well.
Mm-hmm.
Yes. Any other
Mm-hmm.
concern?
No, you got 2 minutes with you.
Okay. Sarah, if you have any other questions, I will be happy to address.
Mm-hmm. No, doctor, I don't have
Uh,
any other concern.
okay, and I can see like this situation is very difficult for the family, and it seems really very hard on you as well. But if you need any kind of support, we all are here to help you with that.
Mm-hmm. Okay, all right, doctor. You still have
Thank
one more
you.
minute remaining with you.
Okay. I mean, thank you.
All right. So this was a scenario of end of
Okay.
life care, and we will discuss the approach of basically the end of life care through this
Am I
scenario.
audible?
Yes, you are audible. You're audible. I can hear you. So is the scenario clearly visible on the screen? Can you see the scenario?
Mm-hmm. Yes.
Okay, all right, fine. So in communication cases, remember there are few things that when you are sitting outside, what you should be doing in those 5 minutes, what you should be doing. The most important thing to do in the communication case is do not write anything on the paper until and unless there are some legal issues like driving, pregnancy, periods issues, or these kind of issues you need to write on, you can write on the paper. But otherwise, my advice to everyone is in communication cases, do not write anything on the paper. Do not make up any any approach in your mind before you go inside. Do not make anything beforehand, like any map in your mind before you go inside. The problem is once you go inside, the things completely change when the surrogate keeps on asking you different sorts of concerns and different things that might not be written in the scenario, or that might not be even related to the scenario, like you were not expecting that concerns. So in that way, when you have thought some points in your mind and surrogate is asking you some points, so there is a clash of points. And in such situations you become confused now what to answer and how to answer this concern. So there are few things in this scenario, like there were a few mistakes that I would like to point out
Sure.
in the scenario that I would like to mention. So first of all, we'll discuss end of life care. So end of life care basically is done for those people who have a life expectancy of around 4 weeks. You can say roughly 4 weeks. This pathway is usually applied on those people, and this comes under the umbrella of palliative care. So palliative care is a broad term, an umbrella term, and one of the part of that palliative care is end of life care. So in this scenario is how to discuss end of life care. And furthermore, you made good rapport with the patient, but avoid taking too much history questions in the communication cases. It's good that you check the understanding and check the you were being involved with the surrogate, but avoid taking too much history in the communication cases. That's the first thing. Now, how to begin this scenario? First of all, you will discuss with her that I came here to discuss about your mother's health.
Okay.
Both are on the same page. Just a simple opening that you can use for every communication case. This is something that you can make a general line or thing for every communication case that Miss Sarah, I'm here to discuss about your mother's health condition. But before I go into any further details, I would like to know how far you know about mothers, about the situation, so that we both are on the same page, and then you can build up your conversation depending upon that. So obviously she will tell you a story what happened. As I told you that my mother was admitted 2 months back, she was treated with antibiotics, she improved. So you can say that I can see that you must be really concerned about your mother. And one of an excellent term or phrase that I learned from my colleagues was that from your, you can say to the daughter like this, like in order to show the empathy, you can say that I can see that you are a very caring daughter. I can see that you're really concerned about your mother, and I can see that you're really caring daughter. But I'm here to discuss about the current situation of your mom and our future plan. Is it okay if I begin? And then you can tell her that your mother was admitted here 2 months back as well with an aspiration pneumonia. She improved on antibiotics, but now she is admitted again with another episodes of aspiration pneumonia. So before I go into any further details, I would like to know, do you have any understanding what aspiration pneumonia is and how we usually treat it? Okay, first check the understanding of this thing. Though she mentioned very clearly that my mother had aspiration pneumonia, but first check the understanding of aspiration pneumonia of the daughter. Then you can tell that your mother is admitted in the hospital with an aspiration pneumonia. Unfortunately, we have been trying to treat her. We have given her aggressive treatment with antibiotics. We have given antibiotic for 72 hours. But I am really sorry to say this thing, Miss Sarah, that we were not being very successful. We have not seen a good response in her condition. And unfortunately, her condition is getting deteriorated. And she is doing quite poorly right now. Is it clear, Dr. Maria? The starting point and any questions
Yeah,
up
I
till now?
understand. Like the
Okay.
tone was very empathetic, the way you're
Yes.
mentioning now.
Okay. So try to, just make these, just
Mm-hmm.
like assume that you're sitting in front of someone
Mm-hmm.
and you are just talking to them like this.
Mm-hmm.
So after that, now I told her that she is doing very poorly. Her condition is very critical. She's not responding well to the antibiotics. So obviously the concern will be, or the concern was, that why she is not improving. She was treated with antibiotics 72 months back as well, and she made a dramatic recovery. Why not this time? So you can say that unfortunately, Miss Sarah, antibiotics alone does not make us strong. It's our defense system that makes her more strong. And both antibiotics and a defense system needs to work in a good harmony and needs to be in good health to fight the infections, to fight this aspiration pneumonia, this chest infection she's having right now. So because of her underlying illnesses, so for comorbidities you can use this non jargon term, which is because of her background illnesses. So because of her background illnesses, her response to the treatment is not as it should have been. Furthermore, the aspiration pneumonia, the attack of aspiration pneumonia that she had 2 months back had 2 months back had made her condition worse. Means that her lungs had suffered some irreversible damage. Unfortunately, that is not repairable anymore. So the important thing to remember in end of life care is reversibility, reversibility, and reversibility. You need to use the terms reversibility very clearly mentioned by the examiners in the feedback. That you need to talk that the illnesses, the background illnesses, the deterioration is irreversible. Because there would be many types of scenarios in which your task is to escalate the plan. In that scenarios, it is going to help you, this reversibility is going to help you to make the surrogate understand that this disease is irreversible and good response to treatment. That's why we are thinking to escalate the plan. Are you getting my point? This is the major point of this scenario, to discuss irreversibility of the illnesses that she is having. Yes, is it clear so far?
Yes.
Okay. Now, next we have the concerns of the daughter. Now, how to bring up the topic of end of life care with the daughter. So now next concern would be that what's the plan now? What is going to be if she is not improving? What's the plan now? So our next plan, before discussing the next plan, I would like to just explain you this thing, that your mother, your mother is doing quite poorly right now. She is in not a good state right now, or she's doing quite poorly right now. So the team is of the view. I'm really sorry to use these terms, Miss Sarah, that your mother is approaching the end of her life. So first, build up a repo, a build up, build up something to tell what end of life care is, because you should not be spontaneous like this, that, oh, okay, our next plan is end of life care. No, first tell that because her condition is so much deteriorated, so the team is of the view that she is approaching the end of her life, unfortunately. So that is why our next plan of management is going to be what we call as end of life care. So this means, are you going to give up on my mom? Are you giving up too early? No, Miss Sarah, we are not giving up. We are going to continue the treatment. By that I mean we are going to continue giving her the care, but we are not going to do any aggressive measure for her. And regarding the giving up on too early, we are not going to give up too early on her. We have not given up too early on her. We have already given up antibiotic for almost 72 hours. And usually, if someone responds to antibiotic, usually we see the response in 36 to 48 hours. But unfortunately, that we haven't seen anything like this in your mom. Now, if you would like, I would like to explain what end of life care is. So, end of life care is usually reserved or is given to those people who are doing quite poorly and who are approaching or who are in the terminal phase of their life. Unfortunately, I'm really sorry to use these terms. So, what we usually do in this type of situation, Ms. Sarah, uh, uh, we stop all kinds of aggressive treatments like antibiotics. Uh, Furthermore, we are going to shift your mom to a side room, which is going to be a more peaceful and quiet and calm room. Furthermore, we are going to open the visiting hours for the family, so family can come and visit your mom and spend time and make memories in her last time. And furthermore, if she is in any pain, we can give her painkillers. If she is having a lot of secretions, we can give her some medications to reduce those secretions. Plus, if she is agitated, we can give her some medications to reduce her agitation, like morphine. Okay, so this is end of life care plan. Is it clear, Dr. Maria, or do I need to repeat anything?
Can you please repeat that?
Okay, so our main aim in end of life care is to keep the patients comfortable during the last time of their life. And how we usually do it, Miss Sarah, uh, we shift the patient to a side room, keep them comfortable. Uh, we open the visiting hours for the family so that family can come and visit and spend time with the mom and make memories. And furthermore, if she's in any pain, we can give her painkillers. If she has a lot of secretions, and so we can give some medications and remove those secretions. Further, if she is too much agitated, we can give her some medications to relieve the agitation, like morphine. If she is having a lot of vomiting or sickness, we can give her some medications to relieve the vomiting and sickness as well. But we are not going to do any aggressive measure in order to do any, like, we will not be doing any active or any aggressive measures, because if we go for any aggressive measures, her body is already too much frail. to handle the pressure of any aggressive or intensive measure.
Yeah.
Next, remember in the scenarios, if it is written that you are supposed to discuss end of life care with the daughter or end of life care with the patient, so it is self explanatory that you will be discussing DNAR with the patient. If it is written or it is not written, it you should be discussing DNAR in every case of end of life care. So in this scenario, you will how to now I've already explained the end of life care to the daughter. Now how will I bring her the topic of DNAR with the daughter? So you will tell her like this that Miss Sarah, as I already mentioned you that she is doing quite poorly right now. So there is a chance, unfortunately, that her heart and lungs suddenly may stop at any moment now. So what we generally
Mm.
do in such situations, we do a process which is called as resuscitation process, in which we give some pressure to the heart, with our hands. We give electrical shocks, to the heart with some batteries. We put some tubes into the throat of the patient, and all these steps are basically done in order to revive the patient, in order to restart the heart, and to bring the patient back to life. So, but in your mother case, we are not going to do any such aggressive resuscitation method process. Why? Because she has already given her wish that she don't want any resuscitation process for her if she is in this kind of state. Is it clear, this resuscitation
Yeah.
process?
Yeah, that's pretty well explained.
Okay, so at the end, if you have time, you can discuss the management, like the supports with the daughter, if you require any help or support from our side. And when she asked you, yes, another concern of the daughter was that can I take her to the nursing home? So you can say that yes, that's a possibility that we can plan. So let me talk to my consultant regard never to take anything on your own. Always help from the senior, that I would like to discuss your plan with my consultant, and then we can plan something for shifting. If she is stable enough, we can shift it back to the nursing home where she can spend the rest of her time.
Yeah.
Yes, any
And
questions?
one thing,
Any? Sorry.
and one thing mentioned that we can offer the support, like what kind of support? Emotional support, like the
Yes,
spiritual one?
yes, spiritual, religious support if the family requires any kind of
Mm.
any kind of ritual and spiritual supports.
Thank you. Yeah.
No, sir.
Doctor,
Sir,
Yes, please.
sir, can I stop the ongoing medications just like Parkinson's and ischemic heart disease drugs, which is already running? So can we stop?
If such type of concerns arise, so what you will do is you're going to discuss this thing with the end of life care team, basically. So there are certain medications, like if they are increasing the agitation, like stopping some Parkinson medications increase the agitation, you can keep on giving them. Okay, like if she is having too much of breathlessness or other ischemic, like those medications as a part of end of life care, like especially those medications, by stopping them the agitation can worsen. You can talk with the primary team to make a plan that what to do now. So in such situation, you will talk to the primary team, and so that you can make a plan regarding her other medications.
And sir, for hydration, nutrition, sir, can we give IV fluid or just wet the
No,
tongue?
no. In end of life care, no
No MD.
fluids, nothing is given.
Thank you, sir.
Doctor,
doctor,
Yes, please.
doctor, in the
doctor,
scenario,
can
in
you?
the scenario,
Okay, can talk.
yeah,
No problem.
okay, in the scenario that already the patient discussed with the patient regarding to the dinar, you
Mm.
needed to repeat again, discuss again with him. Already the
Yes,
GB is discussed with.
yes, you're right. Because the daughter don't know about the dinar, so we have to discuss with her regarding the dinar process. So So I was talking about the daughter. Is my voice clear?
Yes,
Am I audible?
clear.
Oh,
Okay.
clear.
So I was saying this thing that the daughter is not aware of the DNAR. As the Dr. Maria discussed that, are you aware of the... So daughter is not aware of the DNAR status. You can talk to the daughter in a way, ask her that, are you aware about a decision of your mom that she has taken 2 months back with her GP about the DNR? Are you aware of such, decision? And then if she does not know, then you can discuss DNR with the daughter. But in other scenarios of end of life care, if it is not written, even then you are supposed to discuss DNR in end of life care.
Hello,
Yes.
Doctor. Can you repeat how I will prepare her to discuss end of life?
Okay, no problem.
Yes.
So what you will tell her that, Miss Sarah, as I already mentioned, yeah, that your mother is doing very poorly right now, and her condition is quite critical right now. So after reviewing her condition, the team is of the view, the treating team is of the view that she is approaching the end of her life, or she is going to the terminal stage of her life. I'm really sorry to say this thing. So, in such situations, we are not going to give, or we are not going to go for any aggressive form of treatment. And our main aim and purpose is going to be the comfort of your mom in the last or remaining time of her life. And we provide, or this is given, or this supportive care is basically called as end of life care, basically. Yes, is it clear?
Yes, Doctor. Thank you.
Okay. Yes,
Dr.
anyone
Hassan, if
having
you
any
don't,
other questions?
I don't have any question. If you don't mind, can I add one thing here?
Mm-hmm.
Like in real life, if any patient is on an life care pathway, we always stop the whole medication, routine medications. Like whenever we go
Yes.
for the end of life care, we say no
Hmm.
routine bloods, no routine meds.
Yes,
You know,
exactly. Yes,
and
agree.
yeah, so it's better like we can
Agree.
stop the cardiac medication or whatsoever the patient is
Yes,
already on.
you can stop. I just talked
Yeah,
about the Parkinson medications because sometimes stopping the
yeah,
Parkinson
yeah,
medication will worsen the
yeah.
agitation in the patient. So what you can do is you can
Right.
talk to the
Yeah.
primary team. You can bring up the topic to them that what to do
Mm-hmm.
now, and then you can decide accordingly with, in the plan accordingly.
Yeah,
I was
sure.
just talking
Thank
about
you.
those medicines.
And one thing I just learned from you, like I just used to know that IV fluids we can give, but you're
No,
right,
no,
like
no,
we are not supposed
no,
to
no,
give
no, not
any
even IV fluids.
IV fluids.
No, we don't give
This is
IV
new
fluids
for
as well.
me. Thank you.
Okay.
Thank you.
All right. So, I think we can move to our consultation case now. So, I think Dr. Zaki, if you're here, please let me know. I will share your case.
Yes, sir. Please share.
Okay. So, I'm going to share your case in the Zoom chat box, and then you can prepare. We'll starting in 4 minutes.
Okay.
I've shared the case in the chat box. So, let me know, Dr. Zaki, if you're ready. We can start.
Yes, sir. Okay.
Okay.
You can
Before,
start.
just give me a second. Before starting, I would just like to mention few things regarding those who are the beginners here. So regarding the long consultation case, there are two long consultation cases as well, and almost all the skills of PACES exam tested in long consultation case, and you are given 5 minutes outside to prepare your case, and then you are given 15 minutes in which you are supposed to take the history, you need to examine the patient, and you are supposed to answer the concerns of the patient. So three things you need to do in those 15 minutes. uh, and also at the end you will have a 5 minute question and answer sessions with the examiner, like your differentials and investigation and management plan with that patient. In our online session, we are going to do only in 12 minutes. So you will be getting a prompt of 2 minutes at 10 minutes. So your time starts now.
Hello there. This is Dr. Zakia. I'm one of the doctor in the clinic today. Am I speaking to Miss Hannah, the 36-year-old?
Yes, Dr. Ayam.
Miss Hannah, today we are having this meeting to discuss about your health condition. So tell me, what brings you in the clinic today?
So yes, doctor, actually I have been having this problem of aches and pains in my joints, doctor, and these aches and pains in my joints are particularly, how it started. I will tell you. It started from my right elbows, my right fingers, actually, hands, my right hand fingers. Then it went to my elbows, or my wrist, actually, then elbows, then involved my shoulder, and then it involved my left side of the body as well. And this is how this have been, spreading so far, doctor, and it is gradually getting worse. I have SLE in the past. I have lots of issues in the past, but this joint pain is something very new for me.
Okay, I'm really sorry to hear about that, Miss Hannah. This joint pain you're having for the last 2 months, right? For
Yes.
how many months you're having? Okay, is
Too
this the
much.
first time in life you are having this particular pain?
I had it in the past related to my SLE, but that was just,
Mm.
limited to my fingers on and off. Sometimes I feel little pain in my fingers on and off, but this is something different. This is something very different, doctor.
Okay. Other than SLE, you have something, any other disease
Yes,
diagnosed in the past?
I've got high blood pressure. I've got kidney issues
Mm.
as well. Like they call it lupus nephritis as well, doctor.
Mm. Okay. Um, for Miss Hannah, I need to know that this particular pain that you have in your it is only on the left hand or left side of the body, not on the right hand.
No, it is in both sides now.
Okay, it is in both sides, and it is in
Yes,
both hands and both elbows and both
yes,
shoulders, right?
yes, yes, doctor.
Okay. Other than the hands, shoulders, and elbows, any other part of the body is involved, like your toes or your ankles,
No,
any back pain you have?
no.
Okay. For the last 2 months, it is gradually increasing in intensity.
Yes, yes, it is, doctor. It is getting worse.
Okay. Um, and um, how does this pain feel like? It's like very,
I
very
don't know.
sharp pain,
I don't know.
very
No idea.
sharp pain. Oh,
I
okay.
don't know. No idea.
Um, Other than this pain, anything any other thing you have, like swelling of the joints or some redness on the
Yes,
joints, you feel anything?
sometimes on and off. Sometimes they swell, and they
Mm-hmm.
do have some redness as well. Yes,
Okay, okay. So which time, particular time of the day it is more?
the pain is more in the morning. Yes,
It's more in the morning. You feel that
yes,
your body joints are particularly stiff also in the morning?
yes, yes, doctor. They are stiff in the morning as well.
Okay. For if you have noticed over time, like for how much time they remain stiff and how does they get better?
Uh, Usually they get better as the day passes, but the time interval is quite variable. Sometimes they are pretty less. Sometimes they the stiffness remains there whole day as well. I don't know. I can't say anything about it, doctor.
It's okay. Okay. So when you move around, you feel your pain gets better or no?
Yes, it does improve. Yes, as the day passes, it get
Okay.
better.
Out of 10, if you can rate the intensity of pain, what is the intensity of pain?
I would say around 4 to 5.
Okay, any 4 to 5. Okay, how does it get better? You need to take some painkillers, or it gets better on its
No,
own
I'm not taking
by
any painkiller.
activity.
No, I'm not taking
Okay,
any painkiller.
okay, okay. So you told me that you don't have any back pain or neck pain. Only the pain is in
Yes.
your arms and shoulder. Okay, okay.
Yes.
You feel that you are paler than before.
No.
You have any lumps or bumps in the body?
No.
Any weight changes recently?
Yes, maybe I've lost 1 to 2 kg weight as well in this 2 months.
Is it intentional or any change in
No, it's
appetite?
intentional. No, no.
Okay. Any fever you have?
Yes, I'm having fever as well for same 2 months as well.
Okay. And any itching or anywhere on the body?
No.
Any rash on any part of the body?
No.
Any skin changes?
No. No.
Okay. Um, and any night sweats you have?
No, doctor.
How's your sleep? Do you sleep well at night, or you feel pain in the joint and that does not let you sleep?
No, no. My sleep is quite good, quite comfortable.
Okay. Okay. So any significant family history you have?
No.
Okay. Can I see what are the medications you are taking?
Yes, doctor. I am taking leflunomide. I am taking azathioprine. I am
Mm,
taking 5 milligrams of prednisolone. I am taking, this Remipril for my blood pressure, doctor.
mm.
These are my
Okay.
medications.
Okay. Okay. You told me that you have a lupus history also. Can you tell me more about it? Are you taking these medicines regularly?
Yes, I am quite compliant and quite regular with my medications.
Okay. How's your blood pressure controlled for the last few months?
It's okay. Yeah, blood pressure control is fine.
Okay. How's your water works?
Initially they were frothy, and I noticed little blood in them. But then, with the medications and when the disease got little controlled, improved. No, so no problem right now.
So, okay, so now these days you are following up with your kidney doctor?
My last follow was all these follow-ups were almost 4 months back, and at that time things were quite fine.
Okay. So, Miss Hannah, I want to know that any allergies you have?
No,
Okay. Um, how are your periods?
they are quite normal.
Okay. When was your last pregnancy?
Almost last pregnancy was 5 years back.
Okay. Okay. And by any chance you can be pregnant now?
No,
Okay. Miss Hannah, do you smoke?
no,
Do you drink alcohol?
no.
Do you what do you do for the living?
I am, I'm not working. I'm basically a housewife.
Okay. Any I'm sorry, I need to ask this question. Any illicit drugs you might be using?
No,
Okay. How is this affecting your life? How is these symptoms are affecting your life?
I feel extremely tired, doctor. Like doing little activities at my home is making me very tired. Plus,
Mm,
early morning activities like, opening the jars, making the breakfast and these things. That's been pretty difficult.
okay. How any significant travel history you have in the last?
No.
Okay. Miss Anna, I would like to examine you now, and while examining, I will be asking some further questions. Okay.
Okay,
Starting
doctor.
from the general physical examination, I would like to have a look at the patient's hands,
Hmm.
and I would like an adequate exposure of the up till the arms.
Hmm.
I would like
Okay.
to just look, feel, and move, starting from looking at any erythema now, any visible swelling, Then
There
I
is
will
no
touch.
but patient is having tenderness in proximal
Okay.
interphalangeal wrist joints.
Okay. At the palpation, there is tenderness in the proximal interphalangeal and wrist joint, right?
Yes.
Okay. Proximal and wrist joint. Okay. Any nail changes?
No.
No. No. How about the elbows and the shoulder joint? How any movements? I would like to move also
Movement
all the
is
joints.
normal.
Movements are normal.
Yes.
Okay. So I would like to check any skin changes, any on the arms, no. Then I
Okay.
would
No.
like to check at the face of the patient, any
Hmm.
pallor. I would like to have vital chart of the patient also because she is having fever.
Vital
Is she
same as
febrile
patient.
now?
No.
Blood pressure, temperature. Miss Hannah, for
Okay.
how this fever, you think it is high grade or low grade? Have you ever measured it at home?
No, doctor.
Okay. Any headaches you have along with these things?
No.
Okay. Um, okay, I would like to check the oral cavity of the patient also for any ulcerations or anything.
Hmm.
Any visible color changings of the toes of the and the fingers also. I would
No.
like to
Anything else?
check the patient's. I would like to
Hmm.
check the patient's feet for any Achilles tendonitis or any kind of tenderness there. No.
No. You got 2 minutes remaining with you.
Okay. I would like to just check the palpate the back of the patient and the whole from neck to the lower back. Any
All right.
tenderness? How are the movements
No,
of
that's
the
normal. Not required.
spine? Okay, Miss Hannah, what are your concerns?
My concern is, doctor, what could be the possible reason of this aches pain and this tiredness? And do you think my SLE is getting worse, doctor? Are these related to my SLE?
Miss Hannah, it can be one of the possibility that your SLE can be getting worse and and we might need to adjust your dosage and but another possibility is that it can be some other disease which is showing up along with SLE. For that we need to do some further investigations, some blood
Mhm,
tests, and after that we will get back to you.
mhm, mhm, mhm. Okay,
So yeah.
you still have 1 minute
uh,
remaining with.
Miss Anna, I want to check further that either the medicines that you are taking for the SLE, are you taking in the right way? Sometimes I just need to check up on that. Like you are you taking regularly? But you told me that you are taking regularly. Other than this, are you taking in the correct way or any
Yes, I
alteration
am
in
taking my
the
medicines. No, 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 I'm taking my medicines quite regularly, doctor.
quite regularly? Okay. Okay.
Okay, all right, fine. Your time is up now. So now the time for examiner question answer questions. So you are asked to summarize your case and tell me your differential diagnosis.
Okay, Miss Hannah, 36-year-old, she presented with the complaint of joint pain, tiredness for the last 2 months. She is the known patient of systemic lupus erythematosus, but this time this pain is not going away, and it's something different than the previous SLE pains that she used to have. And along with this pain, she's having mild fever also, and sometimes swelling on the joints and also stiffness in the joints.
Mhm.
She's hypertensive and also she's the known patient of lupus nephritis. And
Okay.
on examination, I could only appreciate the mild tenderness on the proximal interphalangeal joints and the wrist joint. Rest of the examination of the joints is unremarkable. And based on this, my differential diagnoses are number one, it can be rheumatoid arthritis, and number one, and number two, it can be it can be the worsening SLE, which is not being controlled by the current medication, and number three, it can be ankylosing spondylitis also, but against that, which is involving the peripheral joints, but against that she is not having currently any spine involvement.
Anything else you would like to
And
consider?
other than this, it can be the
If
no,
there
these
is
three only coming up in my mind.
if there is coexistence of rheumatoid arthritis with SLE, what you call it?
Yeah, mixed connective tissue disease. So
Yes,
it comes in under the
connective.
category of mixed connective tissue disease.
Yes, okay. And there is something which is very similar to mixed connective tissue disease. What is that called? Overlap syndrome.
Similar, yeah,
Overlap syndrome. Okay, fine.
yes.
And if I give you a clue that your patient is also immunocompromised, what you should be considering?
Patient is immunocompromised. It can be infectious, septic arthritis, septic osteoarthritis,
No,
septic
septic arthritis.
arthritis.
You would expect a septic arthritis to present with polyarthritis like this.
No, septic arthritis does not present like this. If
Any
he is
other?
immunocompromised, then
Mhm.
it can be that
Yes.
gonococcal or something like that. Reactive
No.
arthritis,
What is a
gonococcal.
common infection in these people who are immunocompromised? One infection that we always fear them, that they can develop, that can present with weight loss, fever as well.
Yeah, HIV.
No, not HIV. Something viral infection. Very
Viral.
common viral infection in, you know, immunocompromised people.
Epstein-Barr virus.
Okay. Or more importantly, cytomegalovirus.
Okay.
Okay. So tell me,
Cytomegalovirus.
when someone develop a dengue fever, what they have? Do they have joint pains?
Sorry, what is your question?
I'm asking that when someone develops, for example, dengue fever, what they have? Do they have joint pains?
Yes.
When someone has any rubella infection, chikungunya infection, any
Yes.
type of viral infection, do they have joint pains?
Yes, they all have joint pains. Yes.
They all have joint pains. So you can mention the term viral arthropathy, viral arthritis.
Okay. Viral
Okay.
arthritis.
And
Okay.
the classical presentation she gave you, doctor, at first involved my right hand, then it moved to my right elbow, my right
Mm.
shoulder, then it involved the left side of my body.
Okay. Mm.
Okay. Fine. Now tell me your investigation and management plan. This patient has landed in your outpatient department. What will you do with her?
Mm. Investigation. I will do general investigations and specific investigations. General in the form of CBC, ESR, CRP, RFTs, LFTs, electrolytes, and some specific investigations I would like to do in the form of though this patient is having not having any travel history, so but if she's living in epidemic area, then of course viral serology I would like to do for dengue fever, and also I would like to repeat the inflammatory markers which are specific to autoimmune diseases like RA factor, qualitative and
Tell me
quantitative both,
how will
anti-CCP.
how will you tell me how will you test a patient with SLE flare-up? Consider this is SLE flare-up.
Other than ESR, we will do. Also,
Yes. What you will do for ESR flare-up? SLE flare-up,
SLE
sorry.
flare.
Yes,
Yeah,
for SLE
yeah.
flare-up. What?
ESR will be high.
What else? What
Also,
else you will do for SLE
also,
flare-up?
yeah. If we are suspecting that there is rheumatoid arthritis, we will go for the
Now
RA
just
factor
tell me
and
investigation.
anti-CCP.
Tell me investigations for an SLE flare-up.
Anti-double stranded DNA,
Okay, you can
ANA.
do the levels of titers. Okay, what else?
Yes.
Something very important, complement levels.
Complement levels. Yes.
Okay, so how will you manage a patient with SLE flare-up?
Management will be in the multidisciplinary team approach involving the rheumatologist, specialized nurses, occupational therapist, and the if the patient is having a SLE flare, we need to give her the high dose steroids.
Hmm.
Along with that, bone protection and stomach protection in the form of vitamin D, calcium, um, and omeprazole. And we need to counsel the patient regarding the side effects of the medication also. And uh, this is how we control the flare up. And along with that, we need to put the patient on the DMARDs. Like this patient
Hmm.
is taking azathioprine, leflunomide, and we need to treat the comorbidities also, and we need to manage that why the flare ups are coming again and again. We need to manage the DMARDs, their doses. Also, if there is anything particular which is aggravating these flare ups, we need to control that.
All right. Fine. Okay, so I would like to discuss few things about the case, and at the end, I will be taking few questions at the end. So basically, from this case, there are few things. The learning points are that this is how rheumatological scenarios are coming in exam these days. They are already giving you some known rheumatological disorder, and they are testing you for a complication. Usually, they are asking you for any association of those rheumatological disorders in the exam these days. Or third, but very important thing they are asking in the exam is complication related to the medications used in rheumatology, like the immunosuppressive medications. So these are the three aspects they are commonly tested in rheumatology these days in the exam. So from this point of view, if I discuss first of all the history of this case, in the history of this case, detailed rheumatological history is required. Like for example, after you have discussed the joint pains with the patient, that like you will do the Socrates of the pain, means the site, onset, character, radiation, aggravating factors, relieving factors, and all these you will do analyze the joint pain first of all. Once you have analyzed the joint pain, then a good rheumatology history is required in this case. So, how to take a rheumatological history in a way that you don't miss even a single question of rheumatology, and you should be very fluent in asking the rheumatological questions. For example, for example, I will show you on the screen. So, let me know when once my screen is visible. Is my screen visible?
Yes.
But
Okay.
it's blank.
Yes, I will
What
write on.
is
I'll
it?
write on. So, how to take a good rheumatological history? So, basically, the way I used to teach this rheumatological history is basically nail to toe approach. Basically, I used to call it. So, what you will do is Like this is the hand of the patient, for example, this is the arm of the patient, and you are going up the arm, and this is the head of the patient, and then you will come down, this is the heart of the patient. Okay, and then you will come down, these are the kidneys of the patient, and these is the genitals, and these are the legs of your patient. So your history should be starting from the nails. Have you noticed any problems, any changes in your nails? Okay, have you noticed any issues with the nails? Now I'm coming back towards the fingers. That have you noticed that your fingers change color when exposed to cold? The most important question of rheumatology they want in the exam. You cannot forget Raynaud's in the history of rheumatology. So this question of fingers. So have you noticed any changes in the color of your fingers when exposed to cold? Then come to the back of the hand. So I've done with the nails. I discussed fingers. Now I'm coming back to the back of the hand. So have you noticed any thickness, any increase in the skin thickness on the back of your hand? Okay, then you will come back. You will go more proximal. You will discuss the any pain in your hands while working. Any pain in your hands while working, particularly tightening the jars, tightening the shoes, any activity which is leading to pain in your fingers or pain in your hand. I'm asking about any claudication, particularly associated with any underlying vasculitis in the patient. Then you will further go up. You will ask, you will reach the arm here. I've reached here. What I will ask? I will ask this, that have you noticed that you feel pain in your muscles, particularly around your shoulder? Do you feel any pain if I touch your muscles here? Myositis. Do you feel problems in combing your hair as well? Any problems standing up from sitting position? So the question of proximal myopathy should be asked for myositis. Now I am done with this. Now I come to the scalp of the patient. So once I reach the scalp, here I will ask the question of scalp as well. Here. So I will ask the patient, have you noticed any hair loss as well? Okay. Then I will come to the eyes of my patient. Have you noticed any problem with your eyes? Any redness, any grittiness, any irritation in your eyes? Remember, Sjogren's is one of the most common association of rheumatoid arthritis. So if they have already given you a patient of Sjogren, they want you to rule out rheumatoid arthritis. Or if they have a patient of rheumatoid arthritis, they want that you rule out Sjogren syndrome in that patient. Then come to the oral cavity. Any problems with your swallowing? Any mouth ulcers? Any problem with the swallowing? Any problems like mouth ulcers? Because dysphagia is almost associated with every rheumatological disorder. These MCTEDs, overlap, systemic sclerosis, CREST, all of them, they are associated with some sort of dysphagia. Now come down to esophagus of the patient. Have you noticed any heartburn as well? Very common association with MCTDs and these rheumatological disorders. Then regarding the lungs, you can ask, have you noticed any breathlessness, any cough for interstitial lung disease associated with it? Okay. Now you can, with the heart related, you can ask any breathlessness, particularly on lying flat, for any cardiomyopathy associated with it, any racing pacing of heart, like any heart beating very fast, for any associations like cardiomyopathy or any arrhythmias maybe associated. So these you can ask. Now in abdomen, the most important thing to discuss is these kidneys basically. So what you will discuss in these kidneys, you will ask the questions of the renal system. Have you noticed any froth in your waterworks? Have you noticed that any blood, any problem with your waterworks? And then for the bowel as well, you can ask any problem with your bowel, particularly any blood through your back passage, because if there is any vasculitis associated with this, then patient may present to you with some bleeding per rectum or abdominal complaint as well. Next, you will come to the genital areas. You can ask any problem with any ulcers, any sores, any discharge, any ulcers, sores, discharge, or lumps. Ulcers, sores, discharge, lumps from your private areas. ulcers, sores, discharge, or lumps from private areas. This covers Behcet's. This covers reactive arthritis as well. Okay, so that is why this is an important question that you should be asking from the patient. Then you will reach the legs. In the legs, you can ask, have you noticed any rash in your leg? Any history of any previous blood clots? In this way, you can screen your patient from head to toe for all the rheumatological disorders. And you should be very fluent in asking these questions, because once you make this scheme in your mind that okay, patient is sitting right in front of me, a surrogate is sitting right in front of me, I'm just looking at him and I'm asking these questions from nail till his toes, like this. So any questions in this part that I just discussed? Yes, anyone having any questions about the history of a rheumatological case?
Dr. Hassan, if would it be enough if we ask just do you have any problem with the waterworks instead of specifying every other questions regarding
At least give some clues to the patient, so that they can
okay.
give you a big bit of hint. But in generally, if you touch them, they will tell you, okay, this is my problem with the bowels, or with the water, or with the bowl.
Okay, thank you.
Okay, so next, if I come to the examination of this case, first I discuss the history, now coming on to the examination of this case. So basically what you need to examine in a very similar way, the way I told you the history of any rheumatological case. You will start with the fingernails. You will ask the examiner, sir, please, I need a pillow to examine my patient. You will examine the nails of the patient. You will check the proximal interphalangeal joints, distal interphalangeal joints for any tenderness. You will check the wrist joint for any tenderness. You will ask for side effects of, you will ask for this prayer sign, reverse prayer sign you can do in the patient, and quickly you can ask to check the functionality of the hand. Like, can you please button unbutton yourself? That's more than enough. Then you will check the pulses, very important, and to be checked on both sides. Here you will ask the examiner, sir, please tell me if there is any radiofemoral delay in my patient. Even if you feel both pulses, please ask this question from the examiner. If he asks you, why are you asking it? You can say, sir, I would like to know any radiofemoral delay for any kind of vasculitis in my patient. Please, very important to ask this from the examiner. So then, this ask checking the pulse. Now go upward. At the back of the hand, you can check the skin pinch for any systemic sclerosis kind of features in your patient. You will go further up, you will reach the arm. So in the arm, you can check little bit of tenderness, or more importantly, you can check for proximal myopathy in the patient. You will go up, you will go to the scalp. In the scalp, you will look for rash very clearly behind the ear, in the scalp as well. Then you will examine the eyes for any rash above the eyelids, or above the eyelashes, or dermatomyositis rash, or any rash like any malar rash. Then examining the patient for oral cavity, eye examination, oral cavity examination. Coming to the neck, examining the lymph nodes of the patient. Particularly in this case, it was relevant because of some sort of any overlying viral arthropathy going on in the patient. Then you will come down. You will quickly auscultate the heart of the patient. Just check the epic speed. Auscultate the heart. All four areas. Ask the patient to lean forward. Check the back for any crepitations, any fine crackles. You will go to the abdomen. In the abdomen, you can just quickly palpate, but nothing much important. But doing for any kind of radiofemoral delay, for example, this renal artery bruit, for example, you can do it. Then you will go uh, to the legs, or you can examine the patient for any kind of any rash on the legs or any DVT. And particularly at the end, you can ask the patient just to walk for you, check the posture, and ask for any if you are thinking that it could be ankylosing spondylitis or any arthropathy of the back is going on. Then you can go and discuss the that I would like to do a modified Schaubers or tragal to wall distance, and movements of the spine, then it becomes a bit more important. So this is how you will end the examination of this case. It will take time, but you should be having at least 5 minutes with you to examine this patient like this. You need at least 5 minutes to examine like this. So that's why you should be fluent enough to complete all that rheumatological history so that you can have 5 minutes to examine your patient. Now, coming to the differentials of this case. So differentials could be as simple as it could be a flare-up of SLE, then it could be a mixed connective tissue disease, or it could be an overlap syndrome, or it could be a viral arthropathy as well. If they keep on asking you anything more, because when this case came in the exam, they kept on asking more. So they wanted all the causes of joint pain in that patient basically. So because she is having this, she's on long-term steroids as well. So other possibilities it could be simple osteomalacia or osteoporosis as well. But against that, the pain is inflammatory in nature and less commonly mechanic. It is less commonly, mechanical. That's why we are keeping it lower down the list. And furthermore, if they ask you what else, then you can keep the differential of a renal osteodystrophy as well, because of she's already a known case of lupus nephritis. So maybe if she's developing any kind of CKD underlying going on, then you can keep the differential of any this bony joints pain due to secondary to underlying renal involvement, renal osteodystrophy as well in your differentials. Yes, vasculitis you can keep in your differentials as well, but there is no evidence as such, like the pulses are completely normal on both sides, and other type of vasculitis maybe other type of vasculitis like other small vessel, or maybe other medium vessel vasculitis may be going on in the patient, but usually this is what they have calibrated this case as SLE flare up, mixed connective tissue disease or overlap syndrome. Then it could be viral arthropathy, and then it could be secondary to osteomalacia in the patient, and lastly, it could be secondary to any, renal involvement, renal osteodystrophy as well. So these are going to be uh, the differentials of this case. Regarding the concern dealing, so whenever the patient will ask you what's wrong with me and do you think this is related to my SLE, you can say that there could be multiple reasons of these joint pains. It could be worsening of your SLE, which we call as flare up of SLE. Then this could be associated with some other problems in the defense system or other diseases that attack the joints. So maybe another disease is coming up or it's showing up. Then it could be some infections going on in the body because you are on certain medications that make your defense system weak, so maybe it could be associated with that as well. And lastly, it could be related to your medications as well. So this is going to be the concern dealing of this case. So what I'm going to do now, I'm going to admit you right now. I'm going to run some tests for you, which include some blood test. We might need to take some snaps or some x-rays of your joints as well, and then once we have all the details with us, then we'll sit together, we'll discuss your diagnosis and further plan of management. How does it sound to you? And at the end you can just discuss about the, if you still have time, then you can discuss about the help to the patient, because patient had issues of working and all these and problems at home, so you can offer little occupational therapy, OT, to the patient to help her at her home, so that she can manage her activities well. So anyone having any questions from this case, please?
Sir, do the patient need admission?
Yes, it does. Patient is immunocompromised, having fever, having weight loss. So yes, immunocompromised patient with fever, no need to send that patient home, please.
Doctor, what is the difference between overlap and mixed connective tissue disease?
Okay, so overlap syndrome is basically when we call overlap when, if someone has two diseases, for example, this lady has SLE and RA, for example, and she is fitting into the criteria of SLE, plus she is also fulfilling all the criteria of RA as well. Like there are different criteria. So then we say this is overlap. Okay, then if it is mixed connectivity, means that there are some features of one disease, then there are some features of one disease, like, but they are not fitting into one completely. Is it clear? Like she has
It
criteria
is a
of both.
symptom or investigation.
No. This is basically the criteria. There are modified Euler criteria, or there are different criteria. We apply those criteria on our patient, but not, like she has RA, she has SLE, but one, mixed features of all the diseases, but not fitting into, completing all the criteria of RA, not completing all the criteria of maybe SLE. And then there are certain antibodies positive as well, like anti-RNP antibodies as well.
Thank you.
Sir, thank you so much for giving me chance to perform the scenario. I performed after 7 months of break actually. So
No,
it
it's
was
completely
not
fine.
really well, but I learned a lot from it. Thank you so much. It was very excellent, just excellent session. Thank you.
Okay. Yes. Anyone having any other questions, please? Okay. So thank you everyone for joining. Hope to see you.
Sir.
Yes, please.
One last question, please. Hi, sir. Sir, just tell me, like, how was the pattern of how to, like, in a quick setup of examination, how do we get to know if it's a symmetrical, if it's a poly, and asymmetrical? Because in this patient, the patient was saying that initially she had some right side and then she developed the left
Mhm.
side. So can it be a
Yes.
symmetrical or a asymmetrical? Like for me,
No.
symmetrical is,
No.
yeah.
No. It's not at that time of presentation. At that time of presentation, what that patient had, you need to focus on that thing. Forget how it started, because there is a very variable presentation. Like some people with rheumatoid arthritis only just have shoulders and then it involved otherwise. Okay, so though RA comes under the heading of symmetric, but it is not necessary that it will follow this symmetrical pattern, go in this way. So because the patient that is sitting right in front of you, what she tells you, that now it is in both sides. So now it means that, okay, this is something which is bilateral and involving the small joints. So to keep it simple for myself, this is symmetrical and it is polyarthritis.
So no matter how it is presented, like first from the right side and then now on the left side, it has to be just bilateral to
No,
call it a
it can be.
symmetrical.
Yes, exactly. Like symmetrical means that it is uniformly involving multiple joints, like PIPs symmetrically, then going back involving the other wrist like this, like going in this symmetrical pattern.
Okay. Okay. So and one more question: how could be the medication, as you said, can be one of the reasons how they can cause these joint pains?
I was talking about basically prednisolone. So because she's on steroids for a very long period of time, so sometimes osteomalacia or osteoporosis can present with joint pains as well.
Okay. Okay, sir. Okay. Thank you.
Sorry, Doctor, when will be the next session? Because
I will try to. Yes, I will try to have a session, inshallah, tomorrow as well at the same time.
Okay, thank you very much.
Thank you. Thank you everyone for
Can I
joining.
take a case tomorrow?
Yes, sure. You can take
Okay.
tomorrow, no problem.
Okay. Thank you.
Thank you
Thank you.
very much, Dr. Hassan, for this wonderful
Thank you.
session.
Thank you, everyone. Thank you.